I can get this. Hello. Perfect. Good afternoon, everyone. Hello. Perfect. Okay, good afternoon, everyone. My name is Chelsea. I am a patient educator at Boston Scientific, helping with different chronic pain patients. Today, we do have Dr. Grombach from COPC, who's going to be presenting about some of the different treatment options that might help you. Before we get started, I will let you know if you haven't signed in, I will go ahead and pass that clipboard around. Also, if you need a folder, please let me know. We will begin probably in about 2 minutes, okay?
Thank you.
No problem. Okay. Do you have a microphone holder by chance?
Do I have a what?
A microphone holder.
We do not. We have a clip, but it's usually we get some feedback with it. We can try it though.
Okay.
Let's see if it works for Dr. Brombaugh.
Perfect. Thank you. Yeah, they are. She's gonna look for a clip. There you go. And then I will be on the side of it.
Okay, you're on. So,
Great.
thank you.
Thank you.
I'm sure they'll have lots of questions after.
Okay.
And they'll probably holler to have you repeat the question before because they won't be able to hear. I'll try to go around with the mic, but sometimes they'll just start saying their question before I get there. So.
All right. Well, thanks a bunch.
Yeah, thank you.
All right. Well, thank you all. I want to thank Boston for helping arrange this. This is a beautiful place. I've been with COPC now for 6 years, and they usually keep me over in Westerville, but I get out once in a while, and this is a very nice part of town. So glad to be with you all today. Today we're going to go over some stuff that we do at COPC that is options for folks. Everything we're going to be talking about is elective care. This is, so it's not for everybody, but it is potentially for everybody. And whenever we look at our folks that come into the Spine and Joint Center, we're looking at options that are going to work best for each individual person. So this is the kind of medicine, it's not like you get a gallbladder attack and you got to see a general surgeon, it's got to come out. Like, these are things that are quality of life issues. So it's going to be, some folks do just great. Some folks have horrible issues that they're struggling with, and they want to try to regain some quality of life. So we look at the various tools that we have available, and we're going to be going over those today. So a little bit about me. Like I said, I've been with COPC now for 6 years. I'm from Southern Ohio, from a farm, still live on a farm. We love farming and horses and all that good stuff. I practice up here. I like the Central Ohio area. I did work down in Southern Ohio for the greater part of the beginning of my career, but now I make the commute up here. I love the Central Ohio Primary Care Organization and working with the Spine and Joint Center. Oh, a couple other things. I teach for Ohio State's University College of Medicine, as well as Ohio University's College of Medicine. So, some things. Basically, this slide is just to say, you know, we have folks come in all the time and they're like, oh, I have pain. So pain can be multifactorial, and it usually is. As we all age, the joints get degenerative. We all get some arthritis, and then we get kind of bumps along the way, depending on what kind of lifestyle we led. So we'll all have varying aspects of either weakness, numbness, pins and needles, some of these burning sensations, sometimes shooting. Sometimes they happen when we're sitting. Sometimes they happen when we're walking or trying to get stuff done. So this is the kind of stuff that we kind of tease out during our initial consult. And again, since this is elective medicine, this isn't stuff anyone has to do. If somebody's got that effect or that negative effect in their quality of life, whether it means just being able to take care of yourself through the day or getting around and doing the activities you want to do, then we ought to look at some of the options that might be able to help you. So, it doesn't have to be like, oh, I'm in so much pain I can't get out of bed. It's like, do I have pain and restrictive issues that are just preventing me from getting out and spending an afternoon with grandchildren or doing some shopping or gardening or any of these kind of activities? Because we want to stay, I think as I've practiced, we've noticed like the key is to keep everything moving. Keep everybody moving. The more we keep moving, the better off everything seems to go. As we get older, if we get a bump in the road and we start like not moving and not doing things, then it's kind of a quick spiral and it doesn't turn out well because our bodies don't have the physical vitality they used to have where we can bounce back. So we want to keep everything moving. So most of you have probably already done stuff like, and these are the kind of things we make sure everyone is already doing, that they're trying, if they can tolerate them, over-the-counter anti-inflammatories. Everybody should be doing some kind of physical therapy. It doesn't mean you have to go to formal therapy, but I think everyone should be doing some kind of daily stretches, movement stuff, kind of warming the body up for the day. TENS unit, a lot of folks like this for the muscle things, and then there's pain medications, either oral pain medicines or in really severe cases, medications through pain pumps. A lot of you may or may not have had knee surgeries or back surgeries, and then various types of injections. So this is kind of like this is a general overview of some basic stuff. So here's some things that are less likely on the forefront of people. And these are things that we do all the nerve blocks and the pain pumps and all that other stuff. But these are some things that I've noticed aren't maybe getting utilized enough. And I think it's because either the family docs aren't aware of it or the patients aren't aware these options are out there. Radiofrequency ablation, that's where we identify like pain nerves that go to the bad joints or the arthritic joints. And this could be in the back or the knees or other sites. And when you do a radiofrequency ablation, you're actually zapping, kind of knocking those nerves out of commission. So you're not hurting the nerves that allow you to walk or function, but we're actually taking out of commission the pain nerves that are restricting our function. And then there's things called indirect decompression. We're going to be talking about that in a little bit. And spinal cord stimulation, which I like to describe to people as a pacemaker for the spine. So, everyone's familiar with what a pacemaker is. These things have been around for a very long time, and they've been re-engineered and reimagined for all kinds of things. In the 20 years I've been practicing, we've been using these spinal cord stimulators for people with various chronic pain issues to get back to function and get back to activity. So, going back on the radiofrequency ablation. Basically, these are minimally invasive. It's done through a fancy needle, and we do this right in the office. Doesn't require general anesthesia or anything. It's a 10 to 15 minute procedure. A lot of times these things can minimize the need of, or these are folks that have already done like a block to confirm where the pain's coming from. And then once we know that we're at a good spot and we think the patient's going to do a good job, we go in with those special needles and do the ablation, the radiofrequency ablation. Basically what that does is it pinpoints the tip of the needle and it activates it. And it heats it up to a temperature that the nerve won't tolerate, but it doesn't do a bunch of tissue damage to the surrounding tissue. So it's very, very focal and pinpoint. And then typically when we do these, most of the folks get anywhere from 6 months to a year relief with these types of procedures. And we just repeat it. You can usually, I'd say my average patient that either that gets these done like in the neck or the low back are very common areas. They'll come in once a year, they'll give me a call and say, the pain's coming back, we just book it and repeat the procedure. Now Vertiflex, these items have been on the market for a while, but they're gaining more and more popularity as they've come out with new generations and I think better physical designs. This is an actual picture of what the Vertiflex is, and this is a whole line of product that is meant, I'm going to bring it back, it's meant for when we have, I'm sure most of you have heard degenerative disc disease or stenosis, but degenerative disc is something we all are going to deal with in our lifetimes as we get older. And a lot of us don't require big surgeries, and we've already had therapy or we're doing meds and the injections, and things just aren't quite doing what we want them to do, or like that kind of circle is getting worn out. Well, these are the next steps. These are minimally invasive placed devices, and as you can see it's got a spacer with arms that actually open up the area, and that effectively opens the disc, opens the hole where the nerves come out, and creates what we call a spacer. And we're going to talk more on this. So a lot of the folks we're looking at, or we look for, we consider candidates for this type of treatment, are folks that may be doing well when they're sitting, but when they go to get up and do something, they're in what we call a flexed position, and that's because of the degeneration in the back. And if they try to walk around or do something, they quite quickly start to develop symptoms in the back and down the legs. And if they sit down, it'll go away. But if they get up again, and this goes back to that functional, we want to get some functional improvement here, that pain will go away. So a lot of these folks, they'll want to go to the store or do some shopping, and they have to get in. They're either walking around on the cart like this, or they're in the scooter because they just can't do it. And really, when you think about it, when you bend forward, that's what you're doing to the spine. You're taking and you're opening up these areas. So you're kind of what we call decompressing yourself. So what is this lumbar stenosis that I'm sure you've all heard? Again, stenosis, there's a lot of terms that get thrown around when you see your doc, and you might look on the internet or talk to a friend. And a lot of these are related. So if you have degenerative disc disease, which is the disc, and it's not as spongy as it used to be, and or you have arthritis in the back joints here, by default, you're going to have stenosis, which means tightness on the nerves. So we use the term stenosis when we talk about all kinds of things. It doesn't just have to be the spine. It can be arteries. It can be, it's most commonly arteries or whatnot. But for us, it's anything in the spine. And when this gets stenotic, nerves don't like that. They don't like to be bumped, rubbed, or irritated. They're very touchy. So we use these various mechanisms to help us unpinch or make it less stenotic of an area. And the easier we can do that, the least invasive we can do that, then the better off everything is. So with this particular Vertiflex, again, consider this like, I like to think of it as like a jack for the spine. When we identify somebody that has this and we think is a good candidate, it's usually 1 or 2 levels that are the problem. What we do is, I personally put folks to sleep for this, but you can do it under what we call twilight. I think it really doesn't matter whether you do twilight or full anesthetic, But the big thing is you do need to get some decent sedation for this. It is a surgical procedure, albeit it's a very small incision we make. And once we get in there, we're going to basically come in, we're going to position you in that kind of flex position. So we open those spine holes in that spine canal, and then we're going to place the spacer in there so that it holds it open. And once we get that in place, then it's a couple stitches and everything's closed up. So the nice thing about this is we're not taking away any bones. We're not shaving what you may have heard a laminectomy or a discectomy. Anytime you hear an ectomy, we're taking stuff out. We're leaving everything alone. We're just going to open the space up, put a spacer to keep it open like a jack, and then get out. So it's got a very quick recovery time. So this whole process takes about 20 to 30 minutes. So, and since it's done through a very small incision, very low risk of infection or complication, because really we're staying on the outside of the spinal canal. We're not messing around with anything on the inside. And then these are usually put in for life. I mean, the expectation is that these are going to be required to keep things open. Now, if something were to happen, they can be removed, but these are typically in for long term. And this is just some folks, these aren't necessarily my people, but this has been out for a while. I can tell you, this is the kind of stuff where I personally have folks that have been able to come down off pain meds or get away from pain meds or minimize it, and the activity level gets back up there. So really, I'm looking for two things when we have somebody with stenosis. Is the stenosis bad enough that it's beyond medications or the meds aren't doing what they used to do? And we've done some therapy, we've done the injections, but it's just not good enough. And a big traditional surgery with screws and rods seems like a big leap, like that's just too much. This is that middle spot. This is something more than just the pill or shots, and it's not a big, invasive, prolonged recovery, fusion type surgery. So, two things. We want to look for decreased need on medications and increased ability to function. So, going on to the second item that we want to go over is the spinal cord stimulator. So we've got all these fancy pictures, all different types of models. The way we typically do it, we keep it very simple. We use a small battery. Most of them are rechargeable. I recommend the rechargeable because they're so small and so easy to maintain. And then we have regular leads that go in. So what this does is you have a battery. It's a pacemaker type looking battery, and it's going to deliver energy through these electrodes to the pain nerves that are on the spinal cord. So when somebody has we can go over different types of scenarios, but this is different than the Vertiflex. There's some crossover in the indications, but this particular device is for people that have more nerve damage that we can't fix, okay? The nerve damage could be due to all kinds of stuff, but if we have a nerve damage issue that's non-fixable, then we can override it. Again, think of that pacemaker where the heart's not beating properly with the electrical impulses. So we override those impulses with something that we can regulate. We're going to do the same thing on the spine. We're going to override those bad electrical signals coming in, telling you you've got pain in the back, pain down the legs, and we're going to tune it out. And that's effectively what this does. So who's a good candidate for spinal cord stimulation? Well, again, this is anyone that's got nerve type pain. People typically have already had one or two or even more back surgeries and attempts to get things corrected, and we just have, for whatever reason, persistent nerve pain. These are typically things that have gone on for some time. A spinal cord stimulator is not something, if you have acute sciatica, we're going to put in. We're going to do therapy, some meds, maybe do an epidural, some steroids. That's your mainstay. These are folks that have had something it's beyond the normal course of treatment. And it's not just used for people that have had, back surgeries. Folks that have had neuropathic issues, painful neuropathies, okay? Not a neuropathy like a very common neuropathy is the feet feel numb or tingly, or they don't quite feel as well as they used to. Same way with the hands. That we're not going to fix. But if it's painful and it's affecting your ability to function, that's where we consider these type of interventions. And some of the other things, just to put names to it, your doctor may call it, and you may know somebody has what they call complex regional pain or reflex sympathetic dystrophy. These are all chronic nerve type issues that will commonly affect hands and legs and feet. Again, other people that we consider for stimulators, obviously this is stuff that has pain. It's not going to do anything good. If we don't have a significant amount of pain to take away, then this kind of stuff's not for you. Again, the numbness and tingling, we're going to have to come up with better medication management for that. But if it's painful, this is where these things come into play. And you may or may not, typically most of my folks that we're talking about for spinal cord stimulation have already been through therapy. We want to try to do the simple procedures like the ablation or epidurals to try to get things under control. So this is just some background information on the stimulators. Most of you, I would assume, have heard about these. They've been around for a very long time, over 40 years. This is something, a lot of my patients will come in and go, is this new or experimental? Does my insurance or Medicare cover this? And the answer is, yeah, this is all completely covered. This stuff's been around for a long time. There's nothing experimental about them. And all the insurance plans cover these. So, again, how does this work? All right. So I think like some of the key points from that cartoon is and I've done spinal cord stim therapy now for the 20 years I've been practicing. It's evolved very nicely. The technology has just become amazing. We have, so Boston's particular system, they can do various types of stimulation for you because everyone's different. Everyone's got a mixture of mechanical or neuropathic and whatever type of pain. So in the old days, we just had like kind of one program. It either worked or it didn't work. And if the patient liked it good enough, we put it in. And that was it. Now we have all different types of stimulation we can do. We can do them together. We can do a whole bunch together. But basically, we're getting better and better at tailoring it to each individual person and their personal likes. And the other thing not to be overlooked is for folks that are wondering, is this a good choice for me? When we go through our consult, if we think somebody's a good choice, you always get to try it. That's probably the biggest blessing with this, is you get to try it first. We try it for usually around 5 days, where you get to go home and see what the actual real deal thing feels like with what we call a temporary unit. It's the real thing, it's just not implanted. The leads are simply put in, and there's an external battery source. So when the patient comes back after like 4 or 5 or even 6 days, they have a very good idea, is this going to make a meaningful difference for me? And if it does, then you're a good candidate. Like I can only identify people that I think are good candidates, but ultimately it's a patient decision. So when we do our trials, at a bare minimum, for us to consider somebody a candidate, we want to see at least half the pain go away. And we want to see an increase in activities. To me, these are the 2 keys. If you can take away half the pain and you can increase somebody's ability to function, usually that's a win. Okay, most folks are going to take that. These are bonus. If you can decrease pain meds, great, but that's not a key component, but it's a possibility. And also better sleep. Again, I think that's related to getting up and activity. So these are all potentials, but I think these are the 2 key components. So this goes on into, I think that last show, again, just emphasizes that it's a personal thing. Results are going to vary depending on the person, but it's all boiled down to your trial. If you have a successful trial, knowing that it takes away most of the pain and increases your function, then this is going to be something that could be a significant improvement in the quality of life and daily activities. So this just kind of reiterates that the one device will cover various things. It can be tailor-made to you, where some folks like to feel it so they know it's on. Some folks don't want to feel anything. They want different combinations. And then this slide this just talks to more about, this has been out for a while, and I think ultimately, if somebody's honest with themselves when they go through the trial, if the trial works, you're going to know. So you should have these things have a very high patient satisfaction and long-term outcome because you get to try it first before we actually do it. And again, it's your decision. We just identify patients that we think would benefit, but ultimately, the proof's in the pudding, so to speak. It's all in that trial. So this is just some information on us. I know you folks are familiar with Central High Primary Care, and I'm from the Spine and Joint Center over there right in front of St. Anne's. So questions? Yes, ma'am.
I'm under the impression that pain usually is your body's way of telling you, stop doing that, it's not good for your body.
Mm-hmm.
So if you take away the pain, are you in danger of damaging your body with what you're doing?
So that is a real common question, and there's some truth to that, but this is a different type of scenario. So the question would be, when you're having pain, isn't that the body's way of telling you to not do something? And in a general sense, I'd say that's absolutely correct. Like if you put your hand on a hot burner, or you overdo something, or you back up into something sharp, you're going to feel pain. That's the body telling you to beware, okay? And that's very important. In these various states where let's just talk about the stim first. So we'll talk about all three. So we have the stimulator, the spacer, and the nerve burning, or the nerve ablation. The stimulators for folks that have chronic nerve stuff. Okay, these nerves have been damaged, and they're giving you bad signals. Okay, and that can be from the neuropathy or what we call radiculopathy. But basically, they all fundamentally mean there's been some damage to those nerves and they're not going to heal right. So they're giving you bad signals. Okay, those signals don't mean that there's actual damage going on in the foot or hand. It's that the nerves are damaged, so they're sending you these bad signals. So the stimulator tunes out those bad signals. Going to the spacer now, the spacer is more of a mechanical functional thing. So those nerves are getting pinched, and that's telling you that they don't like that. So if we put the spacer and open that space up, we're not covering pain up in that scenario. What we're doing is we're actually making a mechanical situation better. And then the third one is ablating the nerves. Again, that's done in a chronic arthritic condition that could be the knees or the back or the neck. Those are bad joints that have arthritis in them, and we all know that there's no cure for the arthritis. We can't just cut it out. It's here to stay. So when we zap the pain nerves, you're not going to do damage on the arthritic joints. The damage is already there. We're taking away the unnecessary feedback from the joint. Now, there's still receptors around these joints that are going to prevent you from hurting yourself, okay? So this is just that pain feedback that gets people that gets people agitated from that chronic pain and from the bad joint. So you are correct. It's good to feel pain if it's an acute situation. But if you have chronic damage, or we're talking about chronic bad joints, there's no safety issue in knocking out that chronic pain signal.
Okay, I got another one.
Yeah, keep them coming.
Okay, with the spacer,
Uh-huh.
how fragile is that spacer? If it takes away the pain, then I want to get back to blue light.
That's
I'm gonna break the-
That's perfect. So the spacer is meant for functional improvement. So getting somebody back up, once the spacer's put in, there are no restrictions. There's usually, like, we want people to take it easy for the first couple of weeks, just to let everything heal. Even though there's not a bunch of stitches, let those heal. But once the healing phase is over, yeah, that titanium, it's a titanium spacer, is stronger than any of your bones.
Stay in place.
It's going to stay in place.
Thank you.
It better stay in place. Yeah, but that titanium is going to win out. It's stronger than the bones, and it's meant for restoration of function. And it's a good week to get out. Finally. I know I had all my brush hogging done this last weekend. Anything else? Yes, ma'am.
I have fibromyalgia,
Mm-hmm.
and I have had all kinds of procedures done on my back, including several implants, and they don't work. But I've had the lowest 5 are fused,
Right.
but it's higher that I have more pain. So, how does fibromyalgia affect after it's passive?
So, another really good question. Fibromyalgia itself is going to kind of be a negative factor on whatever else is going on. It's just going to take, because fibromyalgia is its own thing, it affects the whole body. So if you happen to have a bad back and fibromyalgia, you've got double trouble. You really got a heavy lift. So with my folks that have fibromyalgia and a bad back, like if you have surgery on the back, then I know you've got a bad back. That's where we sit down, we got to think about what's best for you. And it's going to be a matter of where's the pain, because we would never treat fibromyalgia with any of these 3 items we just talked about. But if most of your pain is in your back, then you may be a candidate for some of these treatments. Because if we can get the back feeling better, the fibromyalgia itself can settle down. Fibromyalgia is best treated with light physical activity, range of motion stuff. You can't overdo it with fibro. But you got to do heat and stretches. And if you have a bad back that keeps you from doing your daily activities, your stretches, or yoga, or the Tai Chi type stuff, then your fibromyalgia is going to get out of control. So in a spine like this scenario, we would look to see what can we actually fix. Because I can't do therapy. I can't do your therapy for fibro. We can just recommend the heat and the stretches. But what we can do is look at the spine and see if there's parts of it that are making the back and spine issues worse. And then that's going to make the fibro even harder to control. So for folks that have had previous back surgeries, maybe a stimulator is in order to try. It all depends on the nature of the pain. And if we're not sure, you can always try it. Again, going back to the beauty of the trial. You can always try it, and if it's not great, then it's not good. Oftentimes, people that have had a fusion, those fusions will lock down those bones. And that's what they're intended to do, is to protect that spine, just fuse it. But what happens is The areas above and below that fusion are now taking the wear and tear of our daily activities. So those folks are usually really good candidates for the radiofrequency ablation, or maybe even the Vertiflex if we have what's called adjacent level degeneration and we need to put a spacer in. So all of the things we talked about may be potential options, but it would be something we'd sit down, talk about the nature of the pain, do some exam stuff, and really try to pinpoint what's fibromyalgia pain and what's causing, or what might be spine pain that's complicating each other. Yes, ma'am.
What about pain from a severe curvature of the spine?
So curvature of the spine is going to be degenerative arthritis, most commonly, and breakdown of the disc. Degenerative disc, when the discs are degenerating, the joints in the back get degenerative, and we all start to kind of do this because we're opening up that spine. So if it's mostly arthritis, we're going to talk about doing the radiofrequency ablation because that affects those joints. That helps get that joint pain out of the picture. It's not going to fix your posture. Like if you're in our clinic, we're going to push on you about posturing, and being aware of trying to fix the posture. But if you're posturing because of arthritic joints and you're bending forward to open the joints up, then a radiofrequency ablation might be a great option. If you're posturing because the degeneration and the arthritis has created that stenosis we talked about on the nerves, and that's why you're bending forward, then maybe that spacer that opens those spaces might be the correct option. So it's one of those things where there's lots of options. You just got to sit down and figure out what's best, if any at all. Mm-hmm. Yeah, degeneratives, like especially folks that have a little bit of scoliosis going on, that's just going to wear all those joints out. And those are the folks we're doing a lot of those ablations on. And they work. They're very helpful. I would say all the stuff we do as a standard in our industry is we want to at least take away half the pain or better. If it's not doing that, it's not worth doing. Because nobody likes shots. I've yet to find somebody who enjoys shots. One of these days, right? Well, listen, thank you all for coming out and spending your afternoon with us. If anyone has any questions you think of, you can reach us over at the Spine and Joint Center at COPC. All right, thank you.